Our next speaker is Dr. Phelan. Dr. Phelan is a mother of two, wife for over 40 years, and a physician for 40 plus years. She finished her OBGYN residency in Albuquerque, New Mexico in 1983. Her career has been in academic centers both in Albuquerque, New Mexico and Birmingham, Alabama. Much of her professional career has centered around issues of education, providing cost-effective care to underserved women, and participating in maternal mortality review activities to determine how to best decrease the rising maternal mortality rates. Based on findings, she continues to work with the CDC and the American College of Obstetrics and Gynecology to address some of the contributing factors for maternal deaths in the United States. A link to a copy of her presentation is being put in the chat. When we send the follow-up email with the links to the videos, links to the PowerPoints will also be in the email. And I will pull up her PowerPoint now.
Thank you very much for such a nice introduction. What I'm going to talk about is looking at maternal mortality rates and the data that we are now finding, which prompts me to say that obstetrical providers and OB and emergency room staff need to come up with a way to collaborate. So next slide, I have no conflicts of interest. These are my objectives, which is basically we're going to learn the common language when you're talking about maternal mortality, appreciate the potential role of emergency medicine colleagues in reducing the rate of maternal mortality, and then describe opportunities to improve collaboration among healthcare providers that are intentionally or incidentally engaged in preserving the life and health of the pregnant or postpartum woman. Next slide. So key in any time you talk about statistics or data is to make sure everyone's using the same language. We need to make sure that we have defined and measure things in a way that is reliable and we can use to start solving the problem of maternal mortality. Next slide. Now, there's been a lot of publicity lately about maternal deaths and how poor the United States is faring in this. There's a couple things people need to realize. When you're talking internationally, a maternal death is defined as the death of a woman while pregnant or within 42 days of the end of the pregnancy. And it's only from causes related to or aggravated by the pregnancy or its management, but not from accidental causes. Now, with that definition, with the next slide, you will see that the U.S. has not done well. This is a slide looking at other industrialized nations, and you can see the death rate was many-fold higher than France, Canada, and other countries. Now, you need to realize, however, there are some factors that play into this. Other countries often will not report anything dealing with car accidents, mental health, or substance use disorder in their maternal mortality statistics. Also, quite honestly, the health of many of these countries, their general population, tends to be better than the United States. Our health is getting poorer and poorer. Next slide. So if you look here, even the United States, when compared to a larger group of developed regions, while their rates are going down, ours are going up. And like I mentioned, medical and social health in the U.S. is poor, with violence, obesity, substance use disorder, mental health being major contributors to deaths of reproductive age women and hence pregnant women. Now, to address these problems, we need to have data to understand this. In the past, the data was based solely on the death certificates for women and often looking at what they called O codes, which were ICD-9 codes that implied a pregnancy cause, postpartum hemorrhage, something of that nature. However, this really didn't give the breadth and depth of what contributed to a given woman's death. And that required more detailed review of the records. Next slide. So maternal mortality review committees have been present for many years in various formats. Many were multidisciplinary. They convened at state levels and tried to comprehensively review deaths that occurred within a year of the pregnancy or pregnancy-associated deaths. By that, I mean they would look at all deaths within that period of time, knowing that some of those deaths were not directly related to the pregnancy. It was a motor vehicle accident, something of that nature. Now, the problem with the maternal mortality review committees is that most states, fortunately, do not have huge numbers of deaths. So it gets very difficult to come up with trends or information regarding the causes of the deaths. For this reason, past discussions and dialogues about maternal deaths tended to center around the data from states such as California, New York, Texas, Florida, who had numbers great enough to do some statistical analysis. Generally, small states with smaller numbers, such as many of the Western states, we could not get the information regarding rural issues, indigenous populations, migrants, and so forth, because no one state had enough data, and it was impossible to combine the data across states because each state reported their data in a slightly different format. For this reason, about 10 years ago, next slide, this Center for Disease Control saw this as an opportunity to facilitate this search for information. They came up with not only a formal structure for MMRCs, but they also came up with a database that allowed folks to enter the data in a consistent fashion across all the states. This suddenly started allowing a more in-depth view or inquiry regarding the causes of maternal death, but also allowed us to combine states across a region or the whole country to get a better idea of various social determinants or groups that were at risk, such as indigenous, rural, and so forth. So with this platform now, it is very possible to have a better insight into the causes of maternal death and the factors that play into this. Next slide. Now, again, the definitions used by the state MMRCs in this country are slightly different than the ones used internationally. I've already used the term pregnancy-associated deaths. What this means is a death of a woman during pregnancy or within 1 year of the end of the pregnancy. This has two groups that make up the pregnancy-associated deaths. One is the pregnancy-related deaths. This is a death during or within 1 year of the end of a pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or aggravation of an unrelated condition by the physiological effects of pregnancy. The remaining deaths are deaths within 1 year, the end of a pregnancy, from a cause unrelated to pregnancy. So this might be the death in a motor vehicle accident where the person got T-boned at an intersection or something of that nature. The rest of my talk is pretty much going to focus on pregnancy-related deaths. The pregnancy-associated deaths is a snapshot of what's killing reproductive age women in this country, but I want to focus on the pregnancy-related. So next slide. Now, again, the trends in pregnancy-related mortality in the United States has been increasing. This increase is somewhat artificial in that the data collection has probably gotten much better than it was previously. There's also inclusion now more often of deaths due to substance abuse, violence, and other social determinants that really weren't factored in the 90s. Having said that, however, the maternal death rate in the country is unacceptable. Now, what do mortality review committees do? Next slide. For each reported maternal death, the MMRC attempts to answer the following questions based on a detailed review of the medical records and any other related documentation. Was the death pregnancy related? What was the underlying cause of the death? Was the death preventable? What factors contributed to the death? And if there was some chance of averting the death or preventing it, what specific and feasible actions, if implemented or altered, might have changed the course of events? So now we're trying to identify possible areas of intervention. Next slide. Now, you hear a lot about preventability. The CDC is saying that 80% of pregnancy-related deaths are listed by the MMRCs as preventable. I think many folks in the community assume that that means that something that the doctor or the hospital did resulted in the death. And I want to strongly point out that that is not the case. In fact, many of the provider-related deaths, when you look at those specifically, have decreased over time thanks to better interventions and education. However, when they say now preventable, they're including were there actions by the patient that might have prevented it or caused it? Were there actions that the family might have done that might have changed the trajectory? Provider who contacted the patient or interacted with her. And these were often, as you will see, more than just OB providers. Was it a facility issue, a general healthcare system issue, or was it even a community issue? These all can play a role in the possibility of preventing a death, and they all need to be considered when you try to implement ways to decrease these. Now, next slide. In the analysis, because we now have the ability to combine de-identified data from many states, we are able to determine patterns within regions, within ethnic or racial groups, within locations of delivery or location of residency, risk factors, timing of death. These are all groups or areas that we couldn't really research previously because we didn't have the information across many states. Given this data, next slide, it is possible to come up with an article such as this one, where they combine the data across 36 US states. These were deaths that occurred in 2017 and 2019, and were able to give us a much better view of the ability or the causes of deaths. Now, you might say, well, 2017, 2019, that's kind of dated. Unfortunately, due to the definition that we have to wait till a year after the death, and then it takes some time to get records and so forth, there generally is about a 2-year to 2.5-year delay between a maternal death and the entry into this database to allow aggregate data. So this time delay is getting shorter, but still is present. Yet this is very useful information. On the next slide, you will see that they came up with the most frequent underlying causes of pregnancy-related deaths. And there were the common ones: hypertensive disorder, pregnancy, cardiomyopathy, infection, hemorrhage. But we also started finding out that there were other causes. Mental health conditions accounted for 23% of maternal deaths, pregnancy-related deaths. They meant mental health due to substance abuse, anxiety, depression, these types of things, or inability to comply with recommendations by the providers and so forth, accounted for 23% of maternal deaths. If you look at the top 7, looking at hypertensive disorders of pregnancy, cardiomyopathy, embolic disease, infection, cardiac coronary condition, hemorrhage, and mental conditions, that accounts for 80% of the pregnancy-related deaths in the preliminary data that we have. The other thing that we're able to do is look at data regarding specific regions, and I'll get to that a little bit more. But this was over the 36 states scattered across the country. The next report will likely include a far greater number of states, as most of the states are on the Maria system. If you go to the next slide, another thing that was quite impactful was the timing of pregnancy-related deaths. We often assume that the death due to a pregnancy occurs during the pregnancy, the day of delivery, or very shortly after delivery. However, 53% occurred 7 days to 1 year postpartum, over half. And since most women get discharged from the hospital within 2 to 4 days of the delivery, many of these deaths occurred after the patient had already been discharged from the hospital for their delivery. This suddenly raised the issue that we have far greater number of folks that we need to incorporate in our solutions to try to decrease the pregnancy related mortality rates. Now, a little bit more about my role in this. If you go to the next slide, I've had a very satisfying and interesting career, but when it comes to maternal mortality review, my recent journey has been very useful in many ways. I was the person, in New Mexico, I managed to push through legislation to reestablish the MMRC and served it as clinical chair. I also, given this awareness of the CDC Maria application for data collection, convinced District 8 of ACOG, which is basically all the states you see from New Mexico and north, and then go west all the way to American Guam, excluding California, and that was District 8. And as you well know, it's a very rural district and a very low density population area. And we started working on, can we get combined data to get indigenous information, this type of groups that up to now have been overshadowed by the metropolitan or high density states. With COVID and retirement, I stepped down as the New Mexico MMRC and moved to Alabama, where I had worked back in the 90s, and joined the Alabama MMRC. And now I'm a clinical co-chair on the MMRC and working on what we call the ACOG District 7 MMR work group, which is also trying to look at their involved states and how they might be able to improve within the regional area, the MMR numbers. I'll get back to that later. Now, the next, But one of the things you need to note, both of these states are very rural, poor, and have a large, sort of, shall we say, disenfranchised or disengaged population. So in that way, very similar. It's also kind of interesting. They kind of have a similar shape, and I don't know what that means. Okay, next slide. So now with this insight in particularly New Mexico, where many women, when they are transported, have to travel long distances, I also noticed that up to 40% of the women who died in New Mexico had had encounters with emergency medical services, either emergency departments, emergency transports, both in the months and sometimes years leading up to the death. And we started wondering why. Next slide. Now, one of the things in New Mexico, and this isn't a good rural slide of New Mexico, but I couldn't get a good picture that captured that. You have a very small density of the population overall, but most of that population is clustered in a few larger cities, with the rest of the state being very, very rural. The population density in New Mexico is 17 people per square mile, compared to Tennessee, which is 169 people per square mile, or Kansas, which is 35. Now, this ends up meaning that in New Mexico and similar states, they rely heavily on emergency medical services and the small rural hospitals for all sorts of care, not just medical emergencies or trauma, but conditions complicating current or recent pregnancy. Now, next slide. Now, this has all gotten compounded by the problem that rural hospitals are closing. Between 2010 and 2021, 136 rural hospitals closed, and 19 of those closures occurred in 2020 alone. Next. And that even those hospitals that don't close, 9% of them have experienced a loss of all hospital obstetrical services in this period, such that now 45% of rural US counties had no hospital obstetrical services at all. And this left more than half of all rural US counties without hospital obstetrical services. In fact, in short, this means that obstetrical care in the rural areas is getting into a crisis. Next slide. And during these closures, it's noted that when a labor and delivery department closes, there tends to be more emergency deliveries and more preterm births, and many of these occurring in the ERs, which are a leading cause of infant death. Part of this is due to the decreased OB services. Part of this probably is in the rural counties, you have a decreased median income. Also, states with more restrictive Medicaid eligibility have the greater problems with this. Next slide. So rural communities vulnerability. This was a national sample done 2007 to 2015. And as you noted, there have been a number of hospitals that have closed since then. But again, they looked at severe maternal morbidity, mortality during childbirth among rural and urban residents. And what they found, no surprise, is that it was increased over this period of time in both groups, but particularly in the group of rural residents who, when controlling for sociodemographic factors and clinical condition, had a 9% greater probability of severe maternal morbidity and mortality compared to urban residents. Next slide. Now, I keep mentioning, and you will hear a lot about social determinants of care, of health, and these include the listing here. And you need to realize that the hospitals serving our most vulnerable patients, populations, the very inner city hospitals and rural hospitals, often have the fewest resources. Another problem is, if you look at the next slide, is that many of these folks have problems with driving to a maternity hospital and maternal and perinatal outcomes. Driving distances can be quite long, or both in actual miles or in time. And the greater the risk, the greater the distance, the greater the risk of adverse outcomes. Now, it's unclear, is the actual driving a distance, or is this a more reflection of healthcare delivery deficits when someone has to drive that far? A quick slide again of New Mexico, just because there aren't a lot of cities in New Mexico, so the slide shows quite well. If you look from Albuquerque, which is there in the middle of the map, down straight along the main freeway to a city called, yes, Truth or Consequences. There's a story behind that, but we won't get in there. If you live in Truth or Consequences, there is a hospital there, but it has no maternity services. Your nearest hospitals are Albuquerque, that is 150 miles away. Las Cruces, which is right down near El Paso, which is 75 miles away. And Silver City, which is in the middle of the lower part of the state. And that's only 88 miles away, but you have to traverse 2 mountain passes and about 50 miles of winding mountain roads. So distance is a huge issue, assuming they even have transportation to travel at all. For this reason, a lot of rural folks forego prenatal care or delay in getting prenatal care and will often go to the closest provider for delivery or pre or postpartum complaints, which may be an emergency room in a non-obstetrical hospital. What is actually compounding problems in New Mexico now is the open borders, with huge numbers of patients coming from the south, which have overwhelmed many of these hospitals. So what are the implications for emergency personnel? In the next slide, you'll see that discontinuing basic services such as maternity care in any community increases the pressure on EMS and emergency department professionals to recognize and respond to conditions potentially complicated by a current or recent pregnancy without the support of an obstetrical provider. Go to the next slide. You need to realize that most emergency providers commonly do not know what maternity care providers know very well, that normal physiology of pregnancy changes the presentation and disease progression. Quite honestly, in fact, most emergency room providers want pregnant women out of their emergency rooms as fast as possible. My daughter was an emergency room nurse for many years and would periodically call me with issues that they were having with a pregnant woman, and their obstetrical service, which was in-house, was too busy to come down and help them with. Now, what do I mean by normal physiology of pregnancy changes the presentation and disease progression? Well, let's go through 2 cases, and these are really slight modifications of real cases that resulted in mortality or morbidity. First one is Miss Romero, who's a 28-year-old female who shows up at a local hospital and triaged with blood pressures of 165 to 115, pulse 120, BMI 45. So her blood pressure's up, her pulse is up, her BMI is quite up, and she's complaining of fatigue and burning with urination. Triage nurse, after getting the vitals, sends her to a waiting room. Patient, after waiting for several hours, leaves the ED without treatment and proceeds to an urgent care out of frustration. When you reviewed the records, there was no documentation of a pregnancy on the triage sheet. Next slide. At the urgent care, they did a urine dipstick, which showed protein, ketones, and leukocytes, which is often indicative of a urinary tract infection or a bladder infection. So they diagnosed a bladder infection in the 3rd trimester of pregnancy. At least they knew she was pregnant. They gave her a treatment of a 7-day course of an antibiotic for the bladder infection. There was no documentation of vital signs, including blood pressure. Next slide. The patient obtained the prescription, went home, but 4 hours later, the patient started seizing repeatedly. Family called 911. Since they were very rural in their location, it took 60 minutes for the EMS to arrive at the scene, and the mom and fetus died in transport. Next slide. So this patient, the previous patient had what we call severe preeclampsia that went into eclampsia and resulted in a maternal and fetal death. The ER did not identify, go back a slide. The emergency room did not identify the critical blood pressure, and the urgent care did not appreciate that protein in the urine might be a sign of preeclampsia and did not obtain a blood pressure. Major misses in care. Next slide. Now, another patient is Miss Green, 18-year-old female who comes into the ER with complaints of fatigue, shortness of breath, and cough. Vital signs are reported as normal. Labs are unremarkable. Physical exam is noted as a healthy teen with a few rhonchi, a productive cough. She's diagnosed with bronchitis and sent home with a Z-Pack. Fairly common. Next slide. However, she returns a week later, reporting worsening fatigue, cough, and shortness of breath, and comments, "Ever since I had my baby 4 weeks ago, I've been feeling worse and worse." Her diagnosis? She had peripartum cardiomyopathy. The patient's life was endangered by the failure to note and account for the postpartum status. The urgent care didn't even know she was pregnant. They never asked, had she been pregnant recently? So next slide. So what you see from these is what the MMRCs came up with is that always ask if a patient is pregnant or has she been pregnant in the past few weeks to months. Patient might not think to mention that. And with our obesity, it's sometimes hard to tell that a patient is pregnant. Always take vital signs no matter what the complaint. Realize that normal physiology of pregnancy changes the presentation of disease progression, and maintain a list of dangerous differentials in the peripartum period. In other words, for the ERs and urgent cares to know some of the things that they need to think about that are life-threatening. Next slide. Now, when we started looking at this in more detail, one of the issues is maternal transports. Is this an opportunity to improve the system of risk-appropriate care? And if you go to the next slide, they found that often maternal transports preceded pregnancy-related deaths and had these recommendations that examining modifications and adherence to existing protocols, improving risk-appropriate maternal care systems is important for prevention of pregnancy-related deaths. So some of them were potentially preventable by transfer to a higher level of health care, and some were inadequate responses by emergency medical services or lack of transport. So we looked at this pre-hospital care quickly. Next slide. And what you need to realize is that EMTs and paramedics can be key in the focus of treatment, scope practice, however, varies depending on who is responding. This means there's limited scope of practice, long transports. It may take up to 2 hours for the ambulance to get from the hospital where it's based to the patient and back again. Closest facility may not accept her because they don't have obstetrical services. And quite honestly, there are a lot of dead zones but for cell phone and radios in rural and frontier areas to support the EMTs. Next slide. This gives you a brief idea of the scope of practice. Many of these rural providers are EMT basics who can't even start an IV. They can do a vaginal delivery and recognize complications, but that's about it. Paramedics obviously can do a great deal more, but these smaller communities cannot afford them. Next slide. Another issue is triage. The first case I told you, the triage nurse did not ask if she was pregnant. Next slide. And if you look at the results of this paper, they found that in 86% of the cases, a pregnancy status was not documented. And of those pregnant patients, top blood pressure or systolic blood pressure of over 140 were under triaged. A systolic blood pressure of 140 is nothing in a non-pregnant person with known hypertensive disease. But in a pregnant woman, this can represent preeclampsia or pregnancy-related hypertension and can lead on to severe morbidity and mortality. Next slide. So emergency departments have the problem is the providers are expected to know knowledge in many areas, trauma, cardiac disease, and so forth. And many emergency room physicians are resistant to just one more thing I have to be an expert at. They see OB emergencies relatively infrequently. Their training is limited and there's no ongoing continuing education in many cases for obstetrical care. Obesity obscures the pregnant condition, as I mentioned before, and you can see the slide there as far as the increase in obesity from 1960 to 2014, and it's only continuing to go up. There's no support from an L&D because there is no L&D, and they often lack the equipment, supplies for obstetrical care. And quite honestly, emergency room staff fear the challenges of a pregnant patient. Next slide. Now, given this, ACOG, the American College of OBGYN, the National Association of Emergency Medical Technology have collaborated and agree that there needs to be more education and training on EMS response for obstetrical emergencies, and that less than 30% of the respondents of their survey said they received education or training in the last 3 years on peripartum cardiomyopathy, which is one of the leading causes of maternal death in the postpartum period that presents often to the ER. Next slide. The CDC and the American College of Obstetrics and Gynecology are also working to create a non-obstetric setting working group jointly sponsored by these two groups to start looking at how do we engage providers and systems outside your traditional obstetrical provider in labor and delivery. Next slide. There's been Maternal Health Awareness Week that was jointly sponsored by all of these groups. In January 23rd, 2023, they had a 2-hour webinar on maternal health, on mental health in pregnancy. There was a follow-up one on January 30th that I will talk about in a moment. The next slide. There are other national initiatives looking at how do we collaborate or work with emergency room providers The Alliance for Innovation on Maternal Health, AIM, has focused on quality improvement in obstetric outcome by creating safety bundles, and they have now just releasing a safety bundle on improving obstetrical care within emergency medical services. American College has established a multidisciplinary committee to help come up with guidance, and the ACOG has also sent releases to ask for expanding access and increased quality improvement for maternal care in rural communities to CMS. And the Society for Maternal Fetal Medicine is also looking at how to improve triage activities between hospitals or from the home base to the hospital. Now, next slide. There are some district activities. I know a number of folks in the activity are coming from this part of the US. They established a maternal mortality work group, and with the CDC input have discovered that the rate of maternal deaths from cardiovascular and hypertensive disease in this region far exceeded, was almost twice the rate nationally. So they have set up a goal to try to facilitate states coming up with interventions for decreasing these rates from cardiovascular disease and hypertension. Next slide. American Academy of Family Physicians also recognize this as a problem and are working on this. Next slide. The aspirations that are coming out is that ACOG needs to collaborate with comparable organizations within emergency care, support rural hospitals, possibly develop an OB course comparable to ACLS or ATLS, which are advanced cardiac life support or advanced trauma life support for emergency medical providers, to collaborate more during consultations between the OB services and ED, and provide ongoing education through talks, web-based activities, acknowledge that ER staff in hospitals without labor and delivery are providing care, and provide resources and consultation for those folks. Aspirations include, next slide, I'm sorry. Developing these joint statements, creating disseminated patient-facing materials, as noted in the first presentation. We need to have training, though, that's level sensitive to accommodate the hospital resources, staffing, transport system, and distances to higher levels of care. Transport, if it's 20 minutes, may be feasible, but not if it's 2 hours. This type of thing needs to be acknowledged and addressed. Next slide. ER physicians must be able to reach an OB physician directly. They need to be able to recognize an obstetric emergency, be ready for it, and respond with either stabilization or treatment for the 30 to 60 minutes until OB consult or transport can be arranged. Next slide. Another aspiration is to get ERs to routinely ask the question, are you pregnant? Which they generally are pretty good about asking. Or have you been pregnant in the past 6 months? Because they're the ones seeing the postpartum complications. And if they don't ask this, they don't think of it. Another aspiration, next slide, is to demonstrate through actual emergency room cases how knowing pregnancy or postpartum status impacts the diagnosis and intervention for outcomes. I gave you 2 cases that show this. Finally, next slide. Simulations. Simulations are always more helpful to problem solve in a location as to what the issues are for them and how to address them. These are some simulations that I've been involved with. They're very low tech, but very effective. Next slide. Interdisciplinary collaboration is key. I did a simulation at a freestanding birthing center and run by midwives, and they invited their EMS staff that respond to their calls for transports. And so we did a simulation with both EMS and the midwives and how the handoffs occur, which was very effective. And finally, next slide. An interdisciplinary collaboration is key. In this past year, I did one with EMS providers. These were mainly volunteer volunteer EMTs, which meant they couldn't even start an IV. And we talked about how they can feel more able to handle the emergencies they might deal with. Next slide. So in short, what can you do? Collaborate with your local EMS providers, understand the capabilities of the EMS transport and EDs within your area, provide education on emergency care for pregnant and postpartum women for EMS staff and physicians, work to have a prompt and triage to ask about recent pregnancies. If you have L&D simulations, include your emergency room physicians and staff so they can learn too, and offer simulations for common obstetrically related emergencies for EMS and ED staff so they can be ready for such emergencies, recognize it promptly, respond quickly, and refer as necessary. With that, I will try to answer any questions you might have.
All right, Dr. Phelan, it looks like we have 2 questions. One was related to the infographic that you had towards the beginning of your slide regarding the mortality rates. Someone wanted to know, was it stated that the U.S. counts car accidents, et cetera, in the mortality rate and the other nations do not?
No, that is one of the problems you have, and you need to be cautious when you're looking at comparative data, particularly across countries, is that the data is collected in different ways and may include what on the surface seem very subtle differences, but when you're dealing with such small numbers can make a huge difference in outcome or the data distribution. The US tends to be more inclusive, that anything that is at all might have been impacted by a pregnancy will be included. So car accidents that are happening during a long distance commute to their obstetrical care provider may be included as pregnancy related, because had she not been pregnant, she wouldn't have been on the road. Single car accident might be thought, could this be a postpartum depression and a suicide? So many of these types of deaths that other countries might not even be aware of, because we're in detail looking at all deaths up to a year, we're including them as pregnancy related. Having said all of that, our rate is still unacceptable.
Okay. Sort of to go along with what you just stated, someone commented that, the U.S. counts the entire first year, so that means that the rest of the world only counts the first 42 days?
Ideally, when you're looking at statistics from WHO, the data that was given to the WHO to include should only include the first 42 days, but that's something that may not be done in the more, shall we say, lay media. For WHO documentations, I think that's fairly closely adhered to, I'm told, by the CDC, NIH, and so forth. But how the media may present the data, that may not be the case.
All right, we've got another 2. How do we get more providers to work with doulas?
Improved communication across the groups. This may involve joint classes with staff, find out why physicians are resistant. Much of the resistance will be due to a encounter that they themselves had or associate of theirs had with a doula who became very confrontational, shall we say, or was perceived as confrontational and interfering with the care of the patient. That's unfortunate. I've worked with a lot of doulas along with midwives, and they can be a great advocate for the patient, but they need to work with the physicians and not counter to the physicians. How do you break down those barriers that have been set up because of a bad encounter in the past? Dialogue, being sensitive to each other's side. And since the doulas are the newcomers, that becomes, unfortunately, a little bit more in their role to play. Also, doulas may be coming in and talking to nursing staff and getting nursing support behind it may help be an introduction to the physicians. I think programs that have nurse midwives or accepting of nurse midwives have a better ability to incorporate doulas than ones that are very physician and hospital oriented. It's a change in practice settings, and providers are nervous about giving up on some of the technology for fear that that will hurt the patient, hurt the baby, and increase medical liability, quite honestly.
All right, last question. Is there any governmental funding to provide education for EMS and EDs?
There are getting to be funding sources. HRSA is one. Alabama just recently received some grants from HRSA that will allow them to look at trying to implement things to improve some of the recommendations coming out of the MMRC. And some of that money they have decided will go to trying to help with emergency room education and collaboration. Many states have what is called an ERAS grant. I'm trying to remember what that stands for. It's Enhanced Response to Adverse Situations in Education or something. It's ERASE. And these grants, many, many states, and one of my early slides showed the states that have this, these grants. And these are groups that let me back up. If your state has one of these grants, and usually they're administered through the public health department, you could apply to them to get monies to provide simulations to the ERs. A quick fix would be if your L&D is having simulations, if you have a labor and delivery, and more of them are required by JCO to do that, just have the ED staff or providers come up or do the same one for them. Another resource is often if you have an academic center within your state or county or area, they may be willing to pilot a few simulations in some of the ERs that feed into their catchment area, or perhaps a healthcare plan. We have Presbyterian Healthcare in New Mexico, which has a number of rural hospitals, and they can sponsor or support the simulations. It doesn't cost much to do a simulation. You do not need to have the high-tech mannequin that blinks her eyes and moans and changes her blood pressure. Just even having a mannequin that is has a vagina, so you can practice bimanual massage, and the arms and legs so people can practice putting on blood pressure cuffs, hanging up IVs, these types of things, and working more importantly as a team and finding the glitches within their system that impede their ability to respond. A quick example in a labor and delivery is you have a postpartum hemorrhage, and I imagine this talk on that will come up. There's a number of medicines that are needed. And it was found when they did simulations that the doc would say, I want this medicine, and the nurse would run out to get it out of the Pyxis and run back with that medicine. And then they'd need to run out to get another one, and the Pyxis wouldn't work. And all of those kinds of hassles delayed things dramatically. And the solution was they had an emergency Pyxis drawer, which had all the postpartum hemorrhage meds, and they would have them in the room already for patients who were at high risk, or if it was a low risk patient who then had the problem, they could just run in, open one Pyxis drawer, and have all the medicines at once. It's that kind of problem solving. Another example is postpartum hemorrhage in a small community. They'll start asking for lab work and blood transfusions. And at 2 a.m, you need to talk about who goes to get the blood if you only have two staff with the provider on labor and delivery or in the ED. Who runs the lab work if you don't have a lab tech 24/7? How do you get past some of those hurdles in a realistic fashion in these rural hospitals?
Awesome. The last question I'm seeing is, do you see if currently there are any plans to implement protocols or educations or changes in the documentation settings for the staff in the ER? Like, adding that question you were talking about, asking the female patient, if she was pregnant in the last 6 months.
Not that I know of. The only thing I know of is to ask, well, let me back up. For those who have not dealt with electronic medical records, which most hospitals and emergency rooms have, they are very cumbersome, and it is very hard to get change. And even though you may have 6 hospitals with Epic, those 6 hospitals cannot talk to each other. Each hospital almost has to implement this on their own right now. So I would encourage folks within a hospital setting to talk to their ERs, find out what tool they use for triage. Is it a power form? Is it whatever? And advocate to have in the sentence where it says, are you pregnant? To add a follow-up to that, have you been pregnant within the last few months? And then somehow to make sure that either a positive answer in either of those 2 questions is highlighted to both the eventual provider of care, but also highlights the triage nurse to check for or recognize that this blood pressure of 150 over 110 is critical versus just a routine hypertensive blood pressure in a non-pregnant person. So it really almost has to be done right now on an individual hospital or hospital system basis. I hope that answered the question. That's very frustrating. And quite honestly, some ERs will resist it because they're already having to ask so many questions. They get kind of overwhelmed and tend to put up a barrier. But I think if you can show them how the knowledge of that might allow them to pick up a postpartum cardiomyopathy or preeclamptic hypertensive crisis or other life-threatening etiology, they probably will become more open to that concept of including one more question.
Well, thank you, Dr. Phelan. That was an excellent talk. We appreciate the time you took to educate us today.